So we have a very exciting session with a number of talks in CAR T-cell therapy, both in ALL and lymphoma. So some of the emerging themes we are looking at is using gene-edited CAR T-cell therapy for these are allogeneic CAR T-cells, data being presented from UCL, looking at allogeneic CAR T-cells. So this is an off-the-shelf product, and there have been other CAR T-cell allogeneic products which have been described. A small number of patients treated being presented at this meeting with allogeneic CAR T-cells with deletion of the TCR receptors to abrogate against GVHD risk, and also deleting the CD52 target from the CAR T-cells so that you can use alemtuzumab in the conditioning. So these patients are treated with enhanced lymphodepleting conditioning regimens because these are allogeneic CARs to try and encourage persistence and expansion of the allogeneic CAR and to be able to deliver the enhanced lymphodepleting conditioning. The CD52 receptor is edited, and these patients then are consolidated with allogeneic stem cell transplant. So small number of patients treated, but encouraging early data to, in some ways, to prove the concept, I guess. We're also looking at data emerging from patients relapsing after allogeneic stem cell transplant, ALL patients, where you can have donor-derived CAR T cells. So these are T-cell harvest done on donors of the patients, and then the CAR T-cells infused into patients after manufacturing. And there is a risk of GVHD in this setting. There is a report from a Chinese group which has used in children with ALL. There seems to be a significant GVHD risk, but that also depends upon your conditioning regimen and the CAR T-cell dose that you administer to these patients. Also very encouraging data on supportive care for patients with CAR T-cell therapy. We know that cytokine release syndrome and ICANS are important complications of CAR T-cell therapy, and JAK pathways are involved in cytokine signaling. And Itacitinib is a JAK1 inhibitor. We have seen some data in ASH. There is a data being presented at this meeting, which again shows using Itacitinib as a prophylactic strategy. So given for a few days before CAR T and for up to 4 weeks after CAR T therapy. So randomized trial with placebo-controlled trial showing a significant benefit for patients receiving Itacitinib in both reduction in the cytokine release syndrome and ICANS risk for these patients compared to patients receiving placebo. The response rates and the survival with limited follow-up at the moment looks similar between Itacitinib and placebo group, so that's encouraging. There is a signal for maybe some increased hematotoxicity in the Itacitinib group, a bit of increased neutropenia and thrombocytopenia and that risk. But this is a small study. We are talking of 20 patients in each arm kind of thing. So encouraging data because ICANS and CRS are important side effects, and if we can reduce the risk of these toxicities, then CAR T-cell therapy will be, I guess, more accessible for an increasing number of patients.